Guys, I'm Dr. Monisha. Welcome to NEET PG Aspirant Desk. Today we'll be seeing some questions on abdomen and pelvis. So let's move on to the first question. All of the following are branches of splenic artery except hilar branches, short gastric artery, arteria pancreatica magna, or is it the right gastroepiploic artery? We'll be seeing a little bit about the ventral unpaired branches of the aorta. So here we can see the aorta coming out of the aortic opening of the diaphragm. Okay, and the first ventral unpaired branch is your celiac trunk given at the level of lower border of T12, and the second unpaired ventral branch from the aorta is the superior mesenteric artery given at the level of L1, and the third one is your inferior mesenteric artery given at the level of L3. We'll be seeing about the celiac trunk as the question is on splenic artery. Okay, so the branches of the celiac trunk are the left gastric artery, the common hepatic artery, and the splenic artery. So here we have the very short celiac trunk immediately giving off the left gastric artery. As you can see, it goes upwards to the cardiac end of the stomach, where it is seen to give some esophageal branches to the lower end of the esophagus, and then it supplies the lesser curvature of the stomach and ends up by anastomosing with the right gastric artery. This is all about the left gastric artery. What about the common hepatic artery, the second branch? The common hepatic artery is seen running towards the right, okay, and then it gives off a branch called the gastroduodenal artery, and from then on it is named proper hepatic artery. Okay, so from the proper hepatic artery we see branches right gastric artery which anastomoses with the left gastric artery, and then the proper hepatic artery divides into the right and left hepatic artery. What about this gastroduodenal artery? Gastroduodenal artery travels posterior to the duodenum, okay, and then it divides into two branches. One is the right gastroepiploic artery, and the other one is the superior pancreatico-duodenal artery. The right gastroepiploic artery and the superior pancreatico-duodenal artery. So we have arrived at the answer. The right gastroepiploic artery is a branch from the gastroduodenal artery, which is in turn a branch from the common hepatic artery. Okay, so but we will see in detail about the hepatic artery, which will be useful in other questions. So here we see the common hepatic artery giving off the gastroduodenal artery. As I said before, it divides into right gastroepiploic artery and superior pancreatico-duodenal artery. Then we can see the proper hepatic artery here giving off the right gastric artery, and then it divides into the right and left hepatic artery for the liver, right and left segments of the liver. Okay, and from the right hepatic artery we can see the cystic artery supplying the gallbladder. Okay, so the cystic artery is a branch from right hepatic artery most of the time. So now that we have talked about the cystic artery, we'll see something about the cystic artery. So here we can see the right and left hepatic ducts joining to form the common hepatic duct, and here we have the cystic duct. So the common hepatic duct and the cystic duct joins together to form the bile duct. Okay, this we all know. What happens is here we have the right and left hepatic artery. Okay, and the right hepatic artery is giving off the cystic artery to the gallbladder. Here we have a triangle called the Carlot triangle, the boundaries of which are the cystic duct, okay, and the common hepatic duct. common hepatic duct and the inferior border of the liver. Okay, the cystic duct, common hepatic duct and the inferior border of the liver forms the Callet's triangle, and the contents of Callet's triangle are the right hepatic artery, with its giving the cystic artery and the cystic lymph node of Lund. The cystic artery, right hepatic artery and the cystic lymph node of Lund are the three contents of cystohepatic triangle or Callet's triangle. So, we have talked about the left gastric artery, the common hepatic artery. Here we can see the common hepatic artery giving off the gastroduodenal artery. Sometimes one another branch is given from the common hepatic artery, supplying the superior aspect of the duodenum. What is artery? Mention in the comment section. This is a question for you. Okay, and now we are about to see the splenic artery. Splenic artery is the largest branch of the celiac trunk, and you can see it here running on the posterior aspect of the stomach on the superior border of the pancreas, having a very tortuous course. So what are its border? What are its branches? Okay, so splenic artery gives segmental branches to the spleen first of all, and then it gives short gastric branches to the stomach, and on its way it gives various branches to the pancreas, and then finally it also gives the left gastroepiploic artery that you can see here, that anastomoses with the right gastroepiploic artery from the gastroduodenal artery. So it is a left gastroepiploic artery that is from the splenic artery and not the right gastroepiploic artery. Okay, so let's once again see the question here. All of the following are branches of splenic artery except the right gastroepiploic artery, because only the left gastroepiploic artery is seen coming from the splenic artery. Okay, then another question is all of the following are branches of celiac trunk except. Okay, left gastric artery is from celiac trunk, splenic artery is from the celiac trunk, hepatic artery is from the celiac trunk, right gastric artery is from the hepatic artery. Okay, so one other thing I want to say about the embryology. At first the stomach was in this orientation. Okay, in this orientation. So we had the two layers of peritoneum in the anterior border forming the ventral mesogastrium, and the two layers of peritoneum from the posterior border named as dorsal mesogastrium. And then on, stomach took a turn. How many degrees? It took a turn of about 90 degrees. Clockwise or anti-clockwise? It took a clockwise 90-degree turn. It took a clockwise 90-degree turn, so that the ventral mesogastrium moved on to the right and the dorsal mesogastrium moved on to the left. So within the ventral mesogastrium there is development of liver and the lesser omentum. Within the ventral mesogastrium there is development of the liver and the lesser omentum. You can remember it like this. Ventral mesogastrium, it looks like L, isn't it? So liver and the lesser omentum is from the ventral mesogastrium, and in the dorsal mesogastrium we have the development of the spleen. So the dorsal mesogastrium is divided into two parts. The part between the stomach and the spleen is called as the gastrosplenic ligament. Okay, as the name implies, between the stomach and the spleen it is called as gastrosplenic ligament. Between the spleen and the kidney it is called as the lienorenal ligament. Why am I talking about that? We'll see now. So this is the lesser omentum from the lesser curvature of the stomach, because it has its attachment to the liver. Okay, it is otherwise called hepatogastric ligament. Because it has a little bit of attachment to the duodenum, it is also called hepatoduodenal ligament, hepatogastric or hepatoduodenal ligament. Okay, so in the lesser omentum, we can see two arteries. One is here left gastric artery and the right gastric artery anastomosing within the lesser omentum. Okay, so the two arteries within the lesser omentum are the left and the right gastric arteries. And in the free border of the lesser omentum, we have three structures. As we saw before, we have the hepatic artery and we have the bile duct to the right, and we have the portal vein behind to these two structures. In the free border of the lesser omentum, we have the hepatic artery, and to the right the bile duct, and posteriorly we have the portal vein. So these are the contents of lesser omentum and the free border of the lesser omentum. So what are the contents of greater omentum that is attached to the greater curvature of the stomach? We have the right gastroepiploic artery from the gastroduodenal artery and the left gastroepiploic artery from the splenic artery seen within the greater omentum. So what are the contents of gastrosplenic ligament? Between the stomach and the spleen, we have the short gastric arteries. We have the short gastric artery between the stomach and the spleen in the gastrosplenic ligament. What are the contents of lienorenal ligament? What are the contents of lienorenal ligament? Between the spleen and the kidney, we have the splenic artery itself. We have the splenic artery, and then we have the tail of the pancreas. Though the pancreas is a retroperitoneal structure, the tail of the pancreas is seen within the lienorenal ligament, and we can see pancreatico-splenic lymph nodes. Okay, pancreatico-splenic lymph nodes. So these are the structures within the lienorenal ligament. Okay, for better understanding of the lienorenal ligament, see here you can see the aorta, the retroperitoneal structure, and from the aorta the celiac trunk. The celiac trunk gives off the splenic artery, and you can see the splenic artery, the terminal portion is within the lienorenal ligament, and the tail of the pancreas is within the lienorenal ligament and with the pancreatico-splenic group of lymph nodes. And you also know that short gastric arteries are within the gastrosplenic ligament. Yes or no? Yes. So what about the greater omentum? Okay. So the peritoneum covering the antero-superior surface of the stomach and the peritoneum covering the posterior-inferior surface of the stomach forms the first and second layer of the greater omentum. Then it folds on itself. Okay. So that the second layer forms the third layer and the first layer forms the fourth layer. Okay, it covers almost most of the part of the abdomen and then duplicates itself as a third and the fourth layer and goes on to enclose the lesser sac. Goes on to enclose the lesser sac and then comes back to enclose your transverse colon and the rest of the small intestine, leaving behind the pancreas and the duodenum, most of which is retroperitoneal, as I said before. Pancreas is retroperitoneal except for the tail of the pancreas. Duodenum is also mostly retroperitoneal except for some portions. Please comment it in the comment section which portions are not retroperitoneal. Retroperitoneal. So the greater omentum has 4 layers. So that is asked in one question, how many layers are there in the greater omentum? There are 4 layers in the greater omentum, and the greater omentum is laden with fat and macrophages, so it can seal off any infection in the abdominal cavity. So it is fancily called as a policeman of the abdomen, which you all already know. Okay, so embryologically the gut system is divided into foregut, midgut and hindgut. So just a revision. So we have the esophagus, stomach, duodenum up to the major duodenal papilla. We have the foregut. Then the rest of the second part of the duodenum, third, fourth, and jejunum, ileum, ascending colon, and the right two-thirds of the transverse colon. We have the midgut and left two-thirds of the transverse colon, descending colon, sigmoid colon, rectum and anal canal comes under the hindgut. So the artery of the foregut is the celiac trunk. The artery of the midgut is the superior mesenteric artery, and the artery of the hindgut is the inferior mesenteric artery. All three are ventral unpaired branches from the aorta. So we'll see a little bit about the superior mesenteric artery now that we have seen about the celiac trunk. Superior mesenteric artery is an unpaired branch from the aorta, ventral branch given at the level of L1 behind the neck of the pancreas. As you can see in this picture, it moves on towards the right. Okay, so it gives off the inferior pancreaticoduodenal artery, the first branch that anastomoses with the superior pancreaticoduodenal artery, which is a branch from the gastroduodenal artery. Then it gives off the jejunal and ileal branches, and it also ends up as a ileocolic artery, and then it gives off the right colic artery for the ascending colon, middle colic artery for the ascending colon, and the right two-thirds of the transverse colon. Let us not go in much into detail, but the important thing is the ileocolic artery. Okay, so we'll see a little bit about the ileocolic artery. So here we can see another picture with the jejunal and ileal branches given off. It is giving the ileocolic artery, right colic artery and middle colic artery till the right two-thirds of the transverse colon. So what about this ileocolic artery? Ileocolic artery divides into a superior division and an inferior division. This inferior division of the ileocolic artery gives anterior and posterior cecal arteries for the cecum. But that's not important. It gives off another branch, an end artery called as the appendicular artery supplying your appendix. Okay. So appendicular artery is a branch from the inferior division of ileocolic artery. Inferior division of ileocolic artery. Now that we have seen about the blood supply of the appendix, okay, the appendicular artery and end artery, we'll see about a little bit about the appendix. Okay, so the vestigial organ is having various positions. Okay, it can point towards the inguinal region, mid-inguinal position, pelvic region, okay, 4 o'clock position. It can have a promontoric position. It can have a pre-ileal and post-ileal position with respect to the ileum. It can be near your colon, so that having a paracolic position, but most common of which is a retrocolic position. It is hiding behind the colon with the highest percentage. It is hiding. The vestigial organ is hiding behind the colon. So that is the most common position of the appendix, and that is your retrocolic position. So then the surface marking of the appendix is at the McBurney's point, which is all very trivial information to you, I know. But anyways, we'll cover the topic. Common mistakes can be made here. The McBurney's point is at the junction of medial two-thirds and lateral one-third of the spino-umbilical line. Yes or not? It is at the junction of medial two-thirds and lateral one-third of the spino-umbilical line. Now coming to the appendicectomy surgery, we have a transverse incision or vertical incision, muscle splitting incision. So it is your duty to name the transverse incision and the vertical incision in this picture. You have to name these incisions in the comment section, both of which is used for appendicectomy. So now a little bit about the route of mesentery. So the root of mesentery is nothing but the attached portion of the mesentery. Okay, from where the fleets of the mesentery is hanging about. So the attached portion extends from the duodenojejunal flexure to the ileocolic junction. Okay, the attached portion, the root of the mesentery extends from the ileocolic to the from the duodenojejunal flexure to the ileocolic junction, as you can see in this picture. Okay, so what is the content of this root of mesentery? You can see these two structures within the root of mesentery. What are those? They are nothing but the superior mesenteric vessels. The superior mesenteric artery and vein are seen within the root of mesentery. Okay, so now it is said that the root of mesentery is known to cross certain structures when it is passing from the duodenojejunal flexure to the ileocecal junction. It is crossing the horizontal third part of the duodenum, the aorta, the inferior vena cava, the right gonadal artery, the right ureter, right psoas major. When the root of mesentery itself is crossing all these structures, the superior mesenteric artery and superior mesenteric vein is also known to cross all these structures, so that it is easier for you to remember. So now that we saw that the root of mesentery is extending from the duodenojejunal flexure to the ileocecal junction, what is the structure that is helping to maintain this flexure, duodenojejunal structure? This structure, okay, extending from the crus of the diaphragm to the flexure is helping the duodenum to maintain this flexure. So what is the structure and what is its contents? Okay, so that you must comment in the comment section. Okay, very simple. So one another question. The inferior pancreaticoduodenal artery. Inferior pancreaticoduodenal artery is a branch of superior mesenteric artery. Just now we saw. So we'll talk about the much awaited foramen of Winslow. So here we have the lesser omentum. Yes or not? Lesser omentum. Here we have the free border of the lesser omentum. Imagine as if you are standing near the free border of the lesser omentum and you just look over. So here you can see a pit. Here you can see a pit like that of the Guna cave pit. Okay, you can see a pit and that is called as the foramen of Winslow or epiploic foramen, that is going to connect your greater sac with the lesser sac. Okay, so this uh, hole or pit is going to connect the greater sac that is in front of the stomach with the lesser sac that is behind your stomach. Okay, so that is your epiploic foramen or foramen of Winslow. So now if we take a cross section at the level of epiploic foramen, which is usually taken at the level of T12. Okay, the epiploic foramen can be seen if we take a cross section. So this is a cross sectional view. Okay, at the level of T12, you can see the anterior boundary and the posterior boundary. So the epiploic foramen's anterior boundary is a free border of the lesser omentum with its structures, that is the hepatic artery, bile duct and the portal vein. And the posterior boundary is nothing but here inferior vena cava. So now we have seen the anterior and the posterior boundary, but what about the superior and the inferior boundary? So inferiorly we have the first part of the duodenum. As you can see here, this is right free border of the lesser omentum. So what is here? It is the first part of the duodenum. What is the superior boundary? What is the superior boundary? Here you can see the groove for the inferior vena cava. So what is the lobe present between the groove for the inferior vena cava and the fissure for ligamentum venosum? Tell me, what is the lobe? It is a caudate lobe of the liver. So the caudate lobe of the liver forms a superior boundary and the first part of the duodenum forms a inferior boundary. Anterior boundary is formed by the porta hepatis, which is present within the free border of the lesser omentum, and posteriorly we have the inferior vena cava. So a question: the boundaries of the connection between the greater and the lesser sac, that is your epiboloic foramen, are all except the caudate lobe forms a superior boundary, inferior vena cava forms a posterior boundary, free border of the lesser omentum with the porta hepatis forms the anterior boundary, it is a first part of the duodenum that forms the inferior boundary and not the fourth part of the duodenum. So this is the answer. So now that we have seen about the celiac trunk and superior mesenteric artery, a little bit about the inferior mesenteric artery. Inferior mesenteric artery is given at the level of L3, an unpaired ventral branch from the aorta. It covers the hindgut so that it gives the left colic artery, which covers the rest of the transverse colon and the descending colon, and it gives off sigmoidal arteries to cover the sigmoid colon, and then it continues as the superior rectal artery. The inferior mesenteric artery continues as superior rectal artery to supply the upper portion of the rectum, upper part of the rectum. So now that we have seen about the upper part of the rectum, we will see about the rest of the rectum. So the upper part of the rectum is supplied by superior rectal artery, which is a continuation of inferior mesenteric artery. So the middle part is supplied by the middle rectal artery, which is a branch from the anterior division of internal iliac artery. Middle rectal artery, a branch from the anterior division of internal iliac artery. And the lower part is supplied by the inferior rectal artery, a branch from the internal podental artery, which in turn is a branch of internal iliac artery. So we have the superior, middle and inferior rectal arteries. Okay, we'll see about the venous drainage of the rectum and anal canal. We have two plexuses, venous plexuses, internal venous plexus, which is present in the submucosal layer, and the external venous plexus, which is present in the subcutaneous part. Okay, from the internal venous plexus, we have the origin of 6 veins that unites together to form the superior rectal vein, which continues like that of the artery as inferior mesenteric vein, and which in turn drains into the splenic vein, which helps in the formation of portal vein. So this superior rectal vein is going to go to the portal circulation. But what about the middle rectal vein? Like that of the artery. Okay, the internal venous plexus gives rise to middle rectal vein as well, and like that of the artery, it drains into the internal iliac vein. The internal iliac vein goes into the common iliac vein. The common iliac vein drains to the inferior vena cava. So it is going into the systemic circulation. And the external venous plexus is going to give rise to the inferior rectal vein. Like that of the artery, it is going to drain into the internal podental vein. So both of which, the middle and the inferior rectal vein, are going to go into the systemic circulation. Okay, or going to go into the systemic circulation, while the superior rectal vein is going to go to the portal circulation. So these venous plexuses are an important site of portosystemic anastomosis. Okay, these venous plexuses are an important site of portosystemic anastomosis. Now, why rectal suppositories work faster and they are more effective than oral medications? That is a question. Okay, because of this extensive venous plexuses within the rectum. Now, if we keep suppository in the lower part of the rectum, it is supposed to go into the middle and the inferior rectal vein, okay, which gets absorbed into the, which gets directly into the systemic circulation, which is without going to go into the liver. But if you keep a suppository high up in the rectum, it will go into the superior rectal vein, which through the portal vein, it is going to go by the liver, taking a longer time and getting metabolized, most of which are getting metabolized. So, anyway, rectal suppositories work faster because of this extensive. Okay, so Thank you, guys. We'll see about now that we have left with the portosystemic anastomosis. We'll continue with in the next chapter. Thank you.